Welcome to part 2 of our webinar series on side effects, minimizing side effects and risk after radiation treatment. This webinar is brought to you by Zero Prostate Cancer and sponsored by Boston Scientific. I'm Jeremy Patch, Senior Director of Patient Programs and Education here at Zero, and we'll hear from our featured speaker, Dr. Daniel Fried, shortly. I'd like to share just a few notes before we get started. Today's webinar is being recorded and will be posted on our website, zerocancer.org, later this week. As soon as the webinar ends, you'll see a link to a survey, and we would love for you to participate so we can get your feedback on this event, as well as an opportunity to share topics you'd like to have covered in future webinars. Tomorrow, you will also receive an email with the link to the recording and the survey. Please submit your questions at any time using the Q&A box. We'll do our best to get to as many questions as possible during and after Dr. Fried's presentation. I'd like to thank Boston Scientific for sponsoring this two-part webinar series. If you missed the live webinar part 1, the recording can be found at zerocancer.org. If you're new to Zero, here's just a bit about us, and you can read our mission statement. Zero advances research, provides support, and creates solutions to achieve health equity to meet the most critical needs of our community. Zero is proud to offer a variety of patient support programs and educational tools, all of which are offered at no cost to patients and families. If you or someone you know is in need of resources at any time, while facing prostate cancer, please share these resources and let them know we are here to help. I'd like to spend just a moment highlighting a few of our support programs. 0360 provides individualized case management to help patients and their families connect with financial assistance programs, navigate insurance, and find other kinds of support, including emotional support and transportation assistance. We offer 2 peer-to-peer support programs. Our mentor program makes one-on-one connections, and we offer virtual and in-person support through our support groups. If virtual support is for you, you can also connect with others affected by prostate cancer in Zero Connect, our private Facebook group, or on Inspire, an online patient forum with more than 40,000 community members. We will also be hosting another webinar on October 22nd at 5 p.m. Eastern Time that will cover findings and developments in radiation from this year's American Society for Radiation Oncology Conference. Join us by registering at the link in the chat. And now please join me in welcoming Dr. Daniel Fried, a board-certified radiation oncologist at Spartanburg Regional and Gibbs Cancer Center and Research Institute in South Carolina. Thank you for being here, Dr. Fried. I will pass it along to you so we can get started.
Thanks very much. Thanks for the opportunity from Zero Prostate Cancer and Boston Scientific to tell you a little bit today about prostate cancer and about treatment strategies, as well as some technologies that have been developed to help decrease the side effects of particularly radiation for prostate cancer. So I'm going to assume that many of you know actually a fair amount about prostate cancer already, but we're going to do just a brief overview of prostate cancer and a little bit of prostate anatomy. Then we'll talk some about treatment options for prostate cancer and specifically about radiation therapy and the use of hydrogel rectal spacers to help decrease side effects from radiation treatment. So a quick overview of prostate cancer. So I assume most of you out there know what the prostate is, but mostly what I want to draw your attention to is the anatomy and basically the location of the prostate. So the prostate is located in a very sensitive part of the male anatomy. Here it is, just below the bladder. The urethra runs right through the middle of it. The rectum sits literally a few millimeters behind it, and the nerves controlling erectile function run right alongside of it. the area called the penile bulb, which controls the blood flow to the penis for erectile function, sits directly below it. So as you might imagine, because of its location, there can be impact on things including urinary function, bowel function, and erectile function as a result of treatment for prostate cancer. Now, a lot of men have urinary symptoms, particularly as they age. And the reason for that for most men is something called BPH, benign prostatic hyperplasia. That is, the prostate gets big. Because it has gotten large, it puts pressure on the urethra as it runs through the prostate, and that can result in a variety of different symptoms, including decreased urinary flow, difficulty with stopping and starting of urine, getting up at night frequently to urinate, and even cause the PSA to rise. Now, PSA is what we use as one of our main screening tools for identifying patients who may have prostate cancer, but it turns out that PSA can be produced not just by prostate cancer, but also by normal prostatic tissue. So the bigger your prostate is, the more PSA can be produced by that prostate. So here you can see an enlarged prostate, and you can imagine that you could have a lot of symptoms related to that. Now, in fact, it is much less common to have urinary symptoms as a result of prostate cancer than it is to have symptoms as a result of BPH. Now, prostate cancer is the most commonly diagnosed cancer in men in this country, other than skin cancers. Over 250,000 men get diagnosed with prostate cancer in this country every year, and the survival rate is very, very high for prostate cancer, especially the 5-year survival rate, because prostate cancer in general is a relatively slow-moving process. In fact, at any given time, about 3.3 million men in this country are living with the diagnosis of prostate cancer, so very, very common disease. There are a number of risk factors for prostate cancer, though, frankly, the primary one really is age. Prostate cancer is a disease of aging. It's very uncommon for men under the age of 50 to be diagnosed with prostate cancer. In fact, over half of patients diagnosed with prostate cancer are over the age of 65. The other risk factors are relatively weak risk factors. It is true that there is some genetic component in that if you have a first-degree relative, that is a father, brother, someone like that, who has prostate cancer, that you are at an increased risk up to about double the risk of developing prostate cancer. But it is also true that most prostate cancers that are diagnosed are not as a result of a strong family history. 1 out of every 8 men in this country will, during his lifetime, be diagnosed with prostate cancer. So it's just a very, very common disease. There is a little bit in terms of race and ethnicity that plays into this, in that if you compare the rate at which Black men are diagnosed with prostate cancer, it is a bit higher than white men. And also, if we look at things like access to care, it is true that certain groups tend to receive less treatment for prostate cancer than other groups. A lot of patients want to know, hey, is there anything I can do in terms of my lifestyle, behavior, anything like that to decrease my risk of developing a prostate cancer? And the answer is there's not anything that is a very strong risk factor. It is true that there's some chemical exposures, chronic prostatitis, and sexually transmitted infections that may give some increased risk, and there may be some things in the diet that may decrease the risk a little bit, but there's not anything like when we look at, say, the association between cigarette smoking and lung cancer. There is not the equivalent of that in prostate cancer. Now, one of the most important things to do in terms of figuring out how to address a prostate cancer is to figure out how bad that cancer is. Because prostate cancer, it exists on a big, broad spectrum, from cancers you could live to be 100 years old and they will never be a problem, to cancers that are truly life-threatening to you. So our first job is really to figure out how bad's that cancer, because how bad it is helps us figure out what's reasonable to do about it. And there are a number of different ways that we go about trying to figure that out. One is the use of something called the TNM staging system. Now, this is the staging system used to stage most cancers, though frankly, in prostate cancers, this has not been necessarily the primary way that we try to figure out the severity of the disease. There's the Gleason score, which we'll talk about that more in just a moment, which gives us kind of a measure of how aggressive the cancer looks under the microscope, generally speaking, from either biopsy or from prostatectomy specimen. Other things that we can use are things like the PSA, imaging studies, which these days includes a very good PET scan called a PSMA PET scan, the prostate specific membrane antigen PET scan. Historically, we had used things like bone scan and MRI, which we do sometimes, but the PSMA PET has really replaced that in a lot of situations. Clinical or physical examination of the prostate goes into this. Now there are certain genomic testing devices that we can use. One called Decipher, which is used to help give something called a genomic risk score and helps us to try to determine how aggressively a cancer might behave. Then there are a number of others out there on the market these days. So let's talk a little bit more about that TNM staging system. So the T stands for tumor or the primary site. So that would be what's going on within the prostate itself. This is determined by both physical examination and often also by imaging studies, and in the post-prostatectomy setting can use the actual pathology from the prostatectomy specimen itself. But this gives us an idea of what the primary extent of the tumor is. Does it get out of the prostate into the surrounding tissue? Does it invade the seminal vesicles or any other organs for that matter? So it gives us the local extent of disease. Then there's the N, that stands for lymph nodes. Now this tells us whether there has been a spread to any of the regional lymph nodes, which would be sort of just to the sides of the prostate and seminal vesicle area, or whether there might be lymph nodes that have gone beyond that area. And the M stands for metastases. So this is the presence of distant disease. In addition, when we're looking at the TNM staging for prostate cancer, we not only use these three things, but we also use the Gleason score and we use the PSA. These all go into determining the TNM stage for prostate cancer. So let's talk a little bit about the Gleason score. So the Gleason score basically, as I had said before, is a way of assessing how aggressively a cancer may behave based on its appearance under the microscope. So typically what happens is you take a biopsy of the prostate, and any place where there's cancer, the pathologist will grade it according to this system. Now, the Gleason score is made of two numbers, each on a scale of 1 to 5, that you add together to get a number on a scale of 2 to 10. The 1 to 5 number is what we call the Gleason grade or Gleason pattern. And this is basically where the pathologist looks at this stuff under the microscope and is asking the question, how different from normal prostatic tissue does this stuff look? The more different it looks, higher it goes on that scale. The first of the component numbers is what's called the primary Gleason pattern or primary Gleason grade. That's the most predominant pattern seen in the sample. If there's any additional pattern, it will get the second number. But if it's all the same pattern, you just get two of the same number. So most men who have, say, a Gleason score 6, what they've got is all pattern 3. You get 2 3s, add them together, you get a 6. Here, we also are looking at the use of risk groups according to Gleason score, okay? So really, risk groups are what we use most in terms of determining what we want to do about a prostate cancer. Now, the risk groups are for patients who have disease that has not become metastatic anywhere, okay? These risk categories are basically low risk or even very low risk, intermediate risk, and high and very high risk. And that really is based primarily on 3 factors. 1, the Gleason score, as you see right here, but 2, the PSA, and 3, the physical examination of the prostate. And then in combination, we look at all 3 of those factors and we place a cancer into a risk category. But by and large, the low and very low risk category is made up of Gleason score 6s. So these days, pathologists have sort of thrown the low end of the Gleason score scale away. Nothing gets called a pattern 1 or 2 anymore. So everything's made basically of 3s, 4s, and 5s, okay? Which means that the Gleason score really these days just goes from 6 to 10. So 6s are the low and very low. 7s, whether they're 3+4s or 4+3s, are the intermediates. And 8 through 10s are the high and very high. Now, a Gleason score of 8, if it's a 4+4, is not nearly as worrisome as a Gleason score that is, say, a 5+3 or a 3+5, because that pattern 5 is the most concerning pattern that we see. All right, so once we figure out what risk category or how worried we should be about a cancer, then we have to think about, okay, so what should we do about it? And there are a lot of different ways of treating or managing prostate cancer. And I say managing quite intentionally because sometimes we're not treating prostate cancer. And this is one of the things that really differentiates prostate cancer from most other cancers, in that many patients who are diagnosed with a prostate cancer, in fact, do not need active treatment, and they go on something called active surveillance. This we'll talk about in just a minute. The other two most common ways of treating prostate cancer are either surgically removing it or using radiation therapy, though there are a number of other ways of dealing with prostate cancer. In terms of local treatments, cryotherapy, which is freezing the prostate, or HIFU, which is an ultrasound heating of the prostate, can both be used. And then in terms of systemic therapies, hormone therapy is very often used. This is basically testosterone-lowering therapy. And then less commonly, chemotherapy, immunotherapy, and targeted therapies. And these are generally administered through medical oncology. So let's talk a little bit about active surveillance. So active surveillance has really gained a great deal of popularity over the last decade or so, because it used to be that basically if you got diagnosed with a prostate cancer, you were going to get treated, okay? Whether it be removed or irradiated or some other form, but generally speaking, it was treated. But now we recognize, based on some very good studies, that many prostate cancers, especially those in the low risk range and even some of those in the intermediate risk range, probably do not warrant an active intervention. Instead, we follow these with active surveillance, and we do that by monitoring these on basically an every 6-month basis with PSA, doing annual digital rectal examinations, and by imaging and biopsies at periodic time throughout, depending on the specifics of the disease. Now, one of the great things about it is that there are very few side effects associated with active surveillance, okay? Now, here it says none known, but I would say this: I do have a number of patients who have a fair amount of anxiety associated with the diagnosis of prostate cancer, and then the knowledge that they are in fact not actively treating it. So I do have some patients who start off on a surveillance program, and even though their disease doesn't change, they decide that they want to get treated for their cancer because of the anxiety associated with the diagnosis. Let's see. Okay, surgery. So surgery is in fact the most common intervention that we use in treatment of prostate cancer in this country. We typically use something called a radical prostatectomy. This is basically typically removes the entire prostate and often the seminal vesicles along with that. There are two main ways of doing that, either as an open prostatectomy or a laparoscopic prostatectomy, which is basically what we refer to it as a robot-assisted prostatectomy. Now, historically, so this operation was developed basically in its current form in 1981 by a doctor by the name of Patrick Walsh, who was the chairman of the urology program at Johns Hopkins University. And he himself did about 5,000 of these operations, all of them in open fashion. So basically that was done with this incision in the lower abdomen and then removing the prostate through that incision. But more recently, over the last, say, 15, 20 years, most prostatectomies, in fact, are now done by putting a bunch of little holes into the low abdomen and using robot assistance to remove the prostate. Both potentially very, very effective ways of treating prostate cancer. But It is a real operation, and it does require general anesthesia, typically overnight stays in the hospital, and it is invasive. The side effects that we worry about related to prostatectomy have primarily to do with the potential for urinary leakage and incontinence and sexual dysfunction. Radiation therapy basically can be delivered in two main different ways. First, we're going to talk a little bit about what's called external beam radiation therapy. You can think of this as radiation from the outside in. So patient is lying on a treatment table. There's a machine that moves around them. It's delivering high energy radiation directed at the prostate. The other way of doing that is something called brachytherapy. And brachytherapy is basically radiation from the inside out. And we'll get to that in just a moment. So this is basically external beam radiation is the most common way that we treat with radiation therapy. These are done as outpatient treatments. Historically, we had done as many as 9 weeks of Monday through Friday treatment, up to 45 radiation treatments. More recently, we have developed techniques for being able to compress those treatment schedules. So now treatments generally are done with somewhere from 5 to 28 radiation treatments. Now, some of the, here we're going to talk more about rectal spacing in just a few minutes, but some of the worst of the side effects that can be possible as a result of external beam radiation or brachytherapy can be mitigated to some extent with the use of rectal spacers. But this does not require general anesthesia or any kind of overnight hospitalization. In fact, it takes about 10-15 minutes a day, and it's completely non-invasive. Side effects are a bit different than surgery. Again, as I was saying, for surgery, it's mostly a leakage and incontinence issue. Here we've listed incontinence, but I'll say frankly, most often what we see is urinary urgency rather than leakage or incontinence, and also the potential for sexual dysfunction. Though this is a little bit less common than for surgery, it is still a fairly common side effect. And one thing that you did not see for surgical side effects is the potential for bowel dysfunction. Again, this is something that rectal spacers have helped us to decrease but not eliminate in terms of potential side effects. So brachytherapy, again, this is radiation from the inside out. This is where we place radiation sources directly into the thing that we want to treat. And in fact, the most common way of doing this historically had been something called a prostate seed implant. This is where we place a bunch of little radioactive capsules permanently into the prostate. Typically, we use an iodine 125 seed for that, and that seed has a 60-day half-life. So what that means in practical terms is that patients have to observe radiation precautions for a period of time, typically about 2 half-lives or so. That is, they have to be careful about their time around children, pregnant women, and so forth. And also that the so-called short-term side effects of a seed implant tend to be dragged out over a many months long period. And for both of these reasons, as external beam technology improved over the years, so back in the 1980s, this was the only way really to deliver an adequate dose of radiation to the prostate to eradicate prostate cancer. But over the years, external beam technology has evolved to where we can deliver essentially an equivalent radiation dose from the outside as what we generally deliver using a seed implant from the inside, and that has caused the popularity of seed implantation to go down quite significantly. Again, with this, you do generally use an anesthesia, either a general anesthesia or a spinal anesthesia. Typically, we've not seen patients actually need an overnight hospitalization, but they do have a catheter typically that's kept in overnight that gets removed the next morning. And that, yes, indeed, this is a fairly invasive procedure. Side effects, again, here can be reduced by the use of a rectal spacer. Same side effects that we saw for external beam radiation, but again, over a slightly more protracted course when we're talking about a seed implant. So here is kind of a quick comparison of the two. If we look over here at the brachytherapy side, what I was describing was a low dose rate seed implant. There's a newer version of that that's called HDR, high dose rate implant, and that uses a temporary source that's just placed actually for a few minutes within the prostate, and it can deliver quite a high dose of radiation to the prostate. We use that quite frequently as a supplement to external beam radiation for our high-risk patients or our unfavorable intermediate risk patients, though frankly, it has not been used very much as what we call monotherapy, that is the sole therapy in treatment of the favorable intermediate risk patients and low-risk patients. External beam radiation, so 3D conformal radiation is kind of old school radiation, okay? We really don't use that anymore for treatment of prostate cancer. We do use this IMRT, intensity modulated radiation therapy. This allows much steeper dose gradients, so a rapid fall off from something you want to treat here to something you need to protect right next to it. We also use IGRT, image guided radiation therapy. This allows us to track the prostate in real time or make subtle fine-tuning adjustments, and it has allowed us to shrink our radiation margins so that we treat a lot less normal tissue, and that has allowed us to escalate the radiation dose that we deliver from the outside. Most radiation these days is delivered with X-rays or photons, but there are a few specialized centers around the country that use protons, which are a slightly different form of radiation therapy. Though the studies looking at these, like a comparison between a good intensity modulated radiation with image guidance, shows that the side effects from the two are basically the same. That is, between good IMRT/IGRT and proton therapy, and that the end result is basically the same as far as disease control. Now, here I want to draw your attention to something called SBRT, stereotactic body radiotherapy. Now, this is an approach that has allowed us really to compress that treatment schedule very dramatically. So for our SBRT treatments, typically we treat the prostate in 5 radiation treatments rather than, say, a 28 treatment external beam, just sort of IMRT approach. This is very, very effective at eradicating prostate cancer, but it's typically only used for prostate confined disease. So we use it for our primarily up through our intermediate risk patients, but not for patients that need to have the lymph nodes of the pelvis treated during their radiation course. So as I was mentioning before, there are a number of other ways of treating prostate cancer. Again, hormone therapy is the main one I want to draw your attention to here. Hormone therapy is basically testosterone lowering therapy. There are 2 main situations where we use hormone therapy. One is for men who have metastatic prostate cancer. That is, it has spread from the prostate to other places in the body, and now we're really just trying to hold off the progression of the disease for as long as we can. Typically, when we look at these patients, we think that these cancers may not be curable, but they are definitely treatable. And one of the main ways we treat them is with hormone therapy. The reason that you would want to do a testosterone lowering therapy is that testosterone is basically like fuel for prostate cancer. So there's certain situations where you want to take that fuel away to fight the cancer better. Okay, so metastatic disease is one of them. The other main situation where we do that is in conjunction with radiation in some patients in order to fight the cancer better. Primarily, that is for our high-risk patients and our unfavorable intermediate risk patients that we typically do include a course of hormone therapy along with radiation therapy. Whereas for our more favorable intermediate or low-risk patients, typically we don't need to include hormone therapy. And it's important because hormone therapy has a lot of side effects. The primary side effects are going to be loss of energy, hot flashes like women going through menopause, loss of sex drive and erectile function, loss of muscle mass and bone density. The list goes on and on. So when you can avoid hormone therapy, it is certainly advantageous to do so. Okay, so let's talk a little bit about ways of trying to reduce the side effects of radiation therapy. And one of the biggest advancements that has been made in recent time is the use of rectal spacers. So let's look again at it.
Dr. Freed,
Yeah, sure.
Apologies. I do have a question related to kind of what you were just talking about before we get into rectal spacers.
Yeah,
So,
sure.
question is, since X-rays or the radiation must go through healthy tissue before it reaches the diseased area, doesn't that mean that all tissue along the way is also damaged?
So yes and no. So it is absolutely true that in order to get into the prostate, so we can just look right here. So here's the prostate. This is a patient in axial image, which means this is like taking a bread loaf slice through the patient. You can see the hip bones here. So the patient here is lying on his back with his feet coming toward you through the screen and his head the other direction. So this is his left side. Here's his right side. So we see the hip bones. Here's prostate. Rectum sits right behind it. Okay. Now, in order to get the radiation in there, you basically have to come from all around the patient. And so it does have to go through the skin and then through other tissues in order to get there. But it turns out that most normal tissues tolerate a low dose of radiation without a great deal of difficulty. But what they do not tolerate well is a high dose of radiation. So spreading that low dose over a pretty broad area helps to decrease the potential side effects of treatment. Also, here where we want to treat a high dose of radiation through the convergence of radiation coming from all around, we need to either have a very rapid dose fall off so that we don't really expose those normal structures to really high doses of radiation, or we need to try to push those structures out of the way. And that's one of the things that rectal spacers do very effectively, is they sort of just push the rectum backwards a little bit and away from that really high dose region right back here at the back of the prostate. Did that answer your question?
Yes, yeah, that one just came in and it was relevant to what you were just talking about, so I wanted
Great.
to get it to you. Thank you.
Perfect. So, okay, so here again, we see the prostate is surrounded by all these normal structures. And you can see here, this is what's called a sagittal image. So this is basically a patient cut down the middle. Here we can see the sacrum and the coccyx, the rectum sitting in front of that, and the prostate right in front of that. This is the cross section of the penis right here. So you can see this area of the penile bulb just below that area that we want to treat. Here's bladder. So again, this is a very delicate part of the anatomy. And so when we are treating with radiation, we are very concerned about the potential damage to this front wall of the rectum, to the bottom of the bladder, or to this area of the penile bulb. So it can, again, impact bowel function, urinary function, erectile function. So one of the things that we know from a number of studies now is that rectal spacing actually can significantly improve patient quality of life and decrease the potential side effects of radiation therapy. And this is true whether you're talking about external beam radiation or whether you're talking about a seed implant. But here, this study specifically looking at external beam radiation therapy, and where basically half of the patients receive a hydrogel that is basically a water-based gel rectal spacer prior to their radiation treatment. And then the patients received their radiation, and they looked to see how what the frequency of side effects, both gastrointestinal and genitourinary, were. And you can see in blue here significantly less toxicity, both from a gastrointestinal standpoint and, in fact, from a genitourinary standpoint. Now, a lot of people were wondering when the data first started coming out, okay, we understand you've pushed the rectum away, and we understand why you would get less toxicity to the rectum, and so less of these bowel side effects, but why are you getting less genitourinary side effects? These would include both urinary side effects and erectile function side effects. Well, it turns out that when you don't have a spacer in, you have to struggle so hard from a radiation planning standpoint to try to protect the rectum that you force additional radiation into the bladder or into the penile bulb. And in doing so, you increase the toxicity of the treatment to those two systems. When you have a rectal spacer, pushing those two structures apart. So basically, if here's your prostate and here's the front wall of the rectum, it pushes them apart from one another. now you can do so much better of a job protecting the rectal wall than in fact you don't, as an innocent bystander, send a bunch of additional radiation into the bladder and penile bulb. And so in fact, we see less toxicity in all three of those domains rather than just in terms of the gastrointestinal side effects. So here we see a cross section where here's the prostate, and in red you can see the sort of the margin that we always place around the prostate in order to account for the potential of a little bit of cancer getting through the capsule and into this area, to account for any potential swelling that might happen during the radiation course, and to account for any little bit of variability in the patient's setup from day to day. So we always build in this extra margin. Well, without a spacer, that margin gets built right into the front wall of the rectum. But with the spacer pushing the rectum away, now you can spare it that very high dose of radiation. And typically we see about 1.3 centimeters of space. And usually we use anywhere from 3 to 7 millimeters of margin back there. So it really helps us quite a lot in terms of reducing the potential of putting high dose of radiation into the rectal wall. This is made of a soft material that just gets placed with an 18 gauge needle into that space. And that starts as two liquids in a double-barreled syringe, immediately becomes a soft, solid gel in that space. And that gel is formulated to be stable for about 3 months, and it just slowly dissolves after that. So if you go looking for it with an MRI or something like that, several months later, then it usually is pretty well dissolved. It dissolves primarily into water, it's resorbed into the body, and it's just excreted as urine. Now, this procedure, typically we do, in my practice, we do it under sort of a conscious sedation, like a colonoscopy sedation, but there's a broad range of how this can be done, anywhere from a local anesthesia to a full general anesthesia. So we have, again, a number of studies that show us that we have not only fewer bowel-related issues, but also fewer urinary and sexual side effects related with the use of these. And this has been growing in its usage quite a lot. I started actually doing these procedures 9 years ago when it first got FDA approval. At this point, more than 500 cancer centers are doing this procedure, and we're approaching now 250,000 patients who have received hydrogel rectal spacers. So a pretty impressive number, so that we know this can be done very safely and effectively. So just to summarize, radiation therapy is a very effective way of treating prostate cancer, but just like anything where you're treating prostate cancer, there's potential for side effects. One of the things that we worry most about is potential damage to the front wall of the rectum as a result of the proximity of the front wall of the rectum to the prostate. So just pushing it away from the prostate helps us to not only protect the rectum itself, but again, as I was saying, actually decreases side effects as far as urinary function and as far as erectile function. So it's been very, very successful and gained quite a lot of popularity over this last 9 years since its FDA approval. All right. So here, I'll just pause for any questions from the audience.
Yeah, thank you so much for that, Dr. Freed, for informative presentation. And we will get to, let me just go to what questions we have. And I know more came in since I asked that last one. If someone had 39 IMRT treatments to the prostate bed and pelvic lymph nodes, could they in later years still get SBRT to particular pelvic lymph nodes?
Yeah, so that's a great question to which I am going to have to give you kind of a nuanced answer. Okay, so there is some limit to the amount of radiation that can be delivered. Now, so you had a prostatectomy, then you had radiation for recurrence to include both the prostate bed and the lymph nodes of the pelvis. If you have a recurrence that is within the lymph nodes that were treated as part of that 39 treatment regimen, then it is sometimes not feasible to deliver enough radiation to that area to be able to eradicate disease that recurs in that area. But a lot of that has to do with the exact location of the recurrence. So if it recurs anywhere near bowel, then it's very difficult to go back and treat that. On the other hand, if you have something that is fairly separated from bowel, then you can consider using something called SBRT. Again, I talked about this a little bit earlier, stereotactic body radiotherapy, where you treat just that small area with a short radiation course to try to get rid of that. But again, it has to be in a very specific area that is able to withstand that additional radiation without causing too much damage to normal tissue.
Thank you. Is it there? I'm going to ask some of these more general radiation questions first, and then there are some related to the spacers, which I'll get to later. But is it common to use SBRT post-prostatectomy for, I'm going to assume this is for a cancer recurrence?
Yeah, so no, it is not, in fact, very common to do that. I would not do that off of a clinical trial. Most commonly, so there was a big clinical trial run recently by the NRG, which is a big cooperative group, basically asking a slight compression of the treatment schedule, looking at a 37 versus a 25 treatment course. And in fact, the preliminary data just came out showing that that 25 treatment course is equivalent to the 37 treatment course. So we are now using a slightly compressed treatment schedule, but in the post-prostatectomy setting, it has not really been used SBRT. The main reason for that is that SBRT is very effective for treating something with a real target. Okay, so if here's your prostate, we can hit that target really well with a little bit of margin around it. But imagine what is your current scenario when you have a prostatectomy, right? So what happens is, so if here's your prostate, bladder sits right on top of it, you remove the prostate, now you pull the bladder neck down into that space that used to contain prostate. And because the bladder neck is not as big as a prostate, the rectal wall actually moves forward and into that space. So now the prostate bed, which used to have prostate, really is made up of bladder neck and the front wall of the rectum. Well, these structures really don't do well with high dose per fraction. That is a high dose per treatment of radiation. And so we have to be very cautious about the use of SBRT in that setting. So again, if it wasn't on a clinical trial, I would advise against doing that. That 25 treatments, I think, is about as short as we reasonably go now off of a clinical trial.
Okay, thank you. If you had a prostate, again, kind of sticking with the same theme, if you had a prostatectomy and then salvage radiation to the prostate bed and lymph nodes, is it safe to receive abdominal CT scans in future years?
Yeah, so CT scans relative to like the amount of radiation that you received from your salvage radiation therapy is literally a drop in the bucket. Okay, now it is important that that the machines be well maintained and that they give you a minimal amount of radiation, but truly it is a very, very small amount of radiation relative to what you had received previously. And there's no contraindication to getting those scans. Having said that, I mean, you should always be cautious about getting too many, like, I mean, you don't want to get them just constantly, but at the same time, if there's some compelling reason to be looking for something in that area, absolutely, yes, you should do that and not worry about the prior radiation that you received.
Okay, great, thank you. Is it typical for urinary side effects from radiation to last 6 months or more? And then there's a second part, can there be long-term effects, and what are the indications that treatment for those effects may be needed?
Yeah, so those are very good questions. So when I talk to my patients about side effects, for urinary side effects for radiation therapy. Basically, I distinguish between the short-term side effects and long-term side effects, okay? Short-term side effects would be those things that happen during the treatment course, maybe up to several weeks following treatment. From a urinary standpoint, these would include primarily like more nighttime urination, more daytime frequency, urgency with urination, maybe some burning with urination, typically building through the treatment course, peaking the week after you finish your treatment, easing off after that. Now, we need to distinguish, though, the long-term side effects, which are actually quite different than the short-term side effects. Just take a quick sip here so I don't start coughing on everyone.
Okay.
So those long-term side effects, the most common of those is urgency, okay? It is fairly common to, and in fact, when you look at patient-reported outcome studies, about 30% or so of men who've had radiation for prostate cancer, whether you ask them a year after their treatment or a decade after their treatment, will tell you they have more urgency than they had had prior to their radiation. That, in fact, so that is the number one complaint. Leakage and incontinence are much less common in the long term than they are, say, with surgery. Though in the short term, sometimes you can get enough of that irritative situation that you wind up with some leakage. But most patients do not, in fact. Some patients, there's an occasional patient who develops some bleeding with urination. This is from a situation called radiation cystitis. This is basically where you have an inflammatory response with the development of some fragile little blood vessels in that very bottom part of the bladder or in the urethra as it runs through the prostate. There can be times when you can get, like if you do something to really increase your intra-abdominal pressure, pick up something really heavy, do something very strenuous, that you can get some leakage from those blood vessels. And anytime you have any blood in your bladder, it comes out looking like blood, okay? You could have, you know, a relatively small amount of blood in a bladder full of urine, and then when you pee, it looks like you're peeing pure blood. So it's pretty startling, but often these things are self-limited. But occasionally, if they're persistent, we have to send patients to a urologist to go in there and basically cauterize those little blood vessels. In very unusual circumstances, but not impossible for this to be the case, if you cannot get good control with that, patients even sometimes have to go for what's called hyperbaric oxygen therapy. This is basically where you're placed into an environment that forces a bunch of additional oxygen into your bloodstream, and that helps promote healing pretty much anywhere in your body that needs it, but it turns out that it's quite effective at dealing with that radiation cystitis situation. If you're having less severe issues, but you're having ongoing burning and things like that, often we deal with those by using medications like Flomax or tamsulosin, or sometimes like Pyridium. If you're having, like, Pyridium is basically like an anesthetic for the urinary tract. So if you're having burning with urination, you can do things like that. If it is persistent burning that doesn't respond well, sometimes we even try to calm things down with like a little course of steroids. So there's a variety of different things that can be done to try to just decrease the acute issues. But generally speaking, long term, like if you're having urgency issues, sometimes putting you on sort of like an antispasmodic kind of agent may be somewhat beneficial, but sometimes it's just kind of the way things are, unfortunately.
Thank you. Appreciate that. Based on the location of tumors on the prostate, are some patients not candidates for spacers?
Yeah, so that's a great question. The short answer is that there is a variability in opinion according to the practitioner. Okay, in my practice, generally speaking, if you do not have extension of disease, where we're really worried that you've got extension of disease through the back of the prostate and into the space between the prostate and the rectum, generally we will place a spacer. Okay, you can have a cancer that's right at the very back of the prostate, but if the MRI and the PET scan and all of our other imaging studies don't indicate any gross disease that we think is likely to be in that space between the prostate and the rectum, then we will place a spacer. So the location within the prostate, not so big a deal as whether it's gotten through the capsule and back into that space.
What, I'm just reading through these, sorry. Well, one is a very straightforward and direct question, which I appreciate. It's just, is it highly recommended to have the spacer to protect the rectum during radiation?
So again, I think that it depends on who you ask. In my practice, it is standard to use a spacer, unless, again, except for in those situations where we're concerned that there might actually be cancer in that space. And what I don't want to do is have cancer that I've sort of pushed more kind of onto the low radiation dose side of the spacer. Sometimes you don't even know that there's any in there. So when we go in to do the spacer, we place a needle into the space between the prostate and the rectum, and we do something called hydrodissection. That is basically separating apart those tissue planes, and that creates a little space where we place the gel. Sometimes, especially for like a really high risk cancer, we'll get the needle into that space and we'll try to hydrodissect, but the tissue planes just won't come apart. And that tells us that even though we didn't see anything obvious on the scans, that there probably is cancer in there, and that we really should not be placing a spacer in that situation. But I would say that is a small minority of patients. Probably if I had to guess what percentage of my patient population gets a spacer, 90-ish%, 80 to 90%, I would say, something like that.
What about, you talked about blood in the urine, but this question is, what about blood clots in the urine after
Yeah.
radiation?
So sometimes what happens if you have a fair amount of blood, like say you have that radiation cystitis situation where now you've had some bleeding. Well, blood's heavier than urine. And so say if you're sitting upright, what happens is, or standing or whatever, it settles at the bottom of the bladder. And if that happens, you can get a clot that forms, and it can block the outlet of urine from the bladder. If that happens and you're in a situation where you cannot urinate, that is actually an emergency that requires a trip to the emergency room so that a catheter can be placed to irrigate clots out of there and to allow the normal flow of urine again. So, sometimes, so clots can be quite serious, especially if they're not attended to. But sometimes they'll just be enough that what happens is when you urinate, you just see them come out as clots, and there's nothing particularly dangerous about that specific situation. It's just that, again, the blood doesn't tend to just sort of free float around in there so much. When you're still, it tends to just collect at the bottom and congeal or clot, and that's where you get those situations from.
Okay, great. Thank you. Appreciate that. We've got more questions, but we are running out of time. So I just want to make sure we get to our survey too, and provide that information. But thank you, Dr. Freed, for all this great information. Much appreciated. As we close our webinar, I want to remind you all attending to please fill out our short survey and to look out for an email with the recording of today's webinar in case you'd like to share it or listen again. I just want to make sure we get that in the chat if we can. But Dr. Freed, again, thank you for your time. Thank you, everyone, for joining us. And we hope that you all have a wonderful evening. Take care.